Good day, everyone. I would like to start by thanking PUA Mindanao. It is my great pleasure to be here today. Special thanks to Dr. Rod Hipol, the PUA Mindanao President, esteemed officers of the chapter, and Dr. Nimrod Firasa for this invitation to talk on hacks in urologic oncology. Here are my disclosures. So treatment decisions and management starts with proper diagnosis of the disease. So I begin with hacks in imaging and diagnosis. The classic lesion of prostate cancer on ultrasound is the hypoechoic nodule in the peripheral zone. Although this is only true in roughly half of the cancers. But the rule is, unfortunately, ultrasound-guided transrectal biopsy has a very high false positivity rate. And this likely stems from the fact that 40% of cancers do not appear as a classic hypoechoic lesion that is described in our textbook. The role of MRI, particularly multiparametric MRI, has gained ground over the past 5 years or so. Several large multi-center randomized trials have been published in the most prestigious scientific journals and have reported the superiority of MRI-guided prostate biopsy. These studies have shown that in biopsy-naive men with elevated PSA and with the use of PIRAD's scoring system, the accuracy of diagnosis of significant prostate cancer can be increased while avoiding biopsy and its morbidities in men who do not need a biopsy. The NCCN now recommends use of multiparametric MRI as part of decision-making tools prior to prostate biopsy. Likewise, the NCCN recommends the use of MPMRI in men with prior negative biopsy but where the suspicion of malignancy has not been ruled out. As a review, multiparametric MRI uses 3 parameters. The first one is DWI, or diffusion-weighted images. This determines the degree of cellularity and neoplastic component, and it's actually the dominant sequence for assessing peripheral zone of the prostate. The T2-weighted images, or T2W, provide high-resolution zonal anatomy and periprostatic anatomy, and is the dominant sequence in the transitional zone. It's also useful for loco-regional staging. And then finally, you have DCE, or dynamic contrast enhanced imaging. And this determines the presence of neovascularization that's associated with cancer. So for those with ambiguous findings, particularly in the peripheral zone, it's the final arbiter. So in summary, multiparametric MRI has been shown to improve diagnosis of clinically significant prostate cancer. It's used as a guide to avoid unnecessary biopsies with its accompanying morbidities and helps avoid the overdiagnosis of clinically insignificant prostate cancer. However, the problem is it can be expensive to have as a modality. It's time-consuming. Some patients would complain that it takes 45 minutes, 1 hour, or even more just to perform this procedure. So those, especially with claustrophobia, would have trouble doing this. And finally, the contrast administration precludes utility in those with allergy or poor kidney function. Hence, there is an increasing attention to biparametric MRI, which uses only DWI and T2-weighted images or sequences, and then omits DCE, which is the part of the MRI sequences that would require contrast. And so we come to our first uro-oncology hack, which is biparametric MRI instead of multiparametric MRI. And actually, there's increasing number of studies already to show that this is actually a viable option. There are studies from the US and Asia showing biparametric MRI is a good alternative to the multiparametric MRI. And actually, studies would show or conclude that diagnostic performance of biparametric MRI is comparable to multiparametric MRI. There are also studies or data from Europe showing the same. Finally, there's a meta-analysis spanning 242 studies involving a total of 2,142 patients. And the conclusion was unanimous in stating that biparametric MRI and multiparametric MRI are comparable. Although pending large multicenter RCTs, current data would suggest that biparametric MRI is a reliable alternative to multiparametric MRI. In summary, the advantages of biparametric MRI are that it's cheaper, there's less examination time, there's no need for contrast, so those with contrast allergy or patients with borderline or poor kidney function can also benefit. The only disadvantage is that the ongoing large randomized trials on non-inferiority of biparametric to multiparametric MRI are still ongoing. Then now we proceed with hacks in surgical management of urologic cancers. The second hack I found useful, although some of you might already be employing, is that of using self-retaining retractors. Aside from providing excellent exposure of the surgical field, you are able to channel your manpower to actual assisting and not just retracting for you. The luxury of having multiple surgical assists is not always present, and special retractors can eliminate this need. So this is a Bookwalter retraction system. It's commonly used for kidney transplant, but definitely is effective in almost any type of urologic cancer surgery. Meanwhile, here's the OmniTrack system. Some surgeons actually prefer this, citing the maneuverability of the poles and arms in this system, and that you're able to adjust down to the last inch. Okay, other ring retractors, such as this, is equally useful. This one is actually a made-to-order retractor at a local machine shop. Okay, so you can have this done in a local metal shop, machine shop. So this is just a quick video on how to set up and mount this self-retaining system. You can appreciate the very good exposure it provides even for deep pelvic surgeries. So our second Uro-Onc hack is the use of self-retaining retractors in your surgeries. The advantages, it can provide superior surgical exposure, can be used in all open cancer surgeries, be it the kidney, bladder, ureter, prostate. It's generally easy to set up and mount and can obviate the need for more assistance involved where there may be limited manpower. The disadvantages, of course, is that some retractors may be expensive and it may require initial capital or investment. The third hack which I use is doing a continuous running suture for vesicourethral anastomosis in open radical prostatectomies. Okay. The textbook description in Campbell and Hinman is that of an interrupted VUA, which uses 6 to 8 throws to anastomose the urethra and the bladder neck. This, of course, remains a feasible technique, but I will show you some potential advantages of the continuous technique. There are at least 2 local studies I will show. First is that of Martinez et al. Involving a retrospective review of outcomes in interrupted versus continuous VUA. In their technique, they used 2 3-0 absorbable monofilament sutures tied together to create a double-arm ligature. First bite at the 5 o'clock on the posterior bladder lip and another at the 7 o'clock on the other side of the ligature. The corresponding urethral side is gathered with an inside-out suture. Sutures are not immediately pulled. Instead, an O-silk is used to secure a loop so that there's still a distance between the bladder and the urethra where there's ample space for you to work and continue your anastomosis. Repetitious passes are made for the left at the 330, 230, 130 position and on the corresponding opposite side. Use alternating mosquito and Kelly forceps to mark the throws to avoid confusion. And then once both sides are done, each throw will be successively tightened, going into the 12 o'clock position, and then prior to tying the 12 o'clock, a leak test may be done. So another local paper which I co-authored during my residency also compared running versus interrupted VUA. Of course, this technique will require a relatively long learning curve, but it's definitely reproducible once you get used to it. So this video just further illustrates the BUA by a continuous running suture. Internationally, a meta-analysis of 9 studies involving 1,475 prostatectomies were done. The study concluded a potential advantage in catheterization time, anastomotic time, and rate of extravasation during cystogram post-op in the continuous technique. Although it did note that most reports are retrospective or small in terms of the number of patient population, so ultimately it's still the surgeon's experience and preference that's important. Uh, However, it's worth considering as a hack using continuous BUA. Potentially, there are superior outcomes in terms of leak rate, time of catheterization post-operatively. It's also cheaper because you only need 2 sutures, whereas you need 6 to 8 sutures when you do interrupted. Of course, a disadvantage would be the initial learning curve for running anastomosis, since textbook description, or most of us were actually trained during residency with an interrupted technique in the BUA during radical prostatectomy. On to the next hack and somewhat controversial topic for uro-oncologists is that of pelvic lymph node dissection for prostate cancer. So the role of lymph node dissection, or LND, in prostate cancer is somewhat blurry, and limiting, or if possible, avoiding it is a useful hack. So this slide shows the different anatomic limits of lymph node dissection. We do know that vital structures like nerves and vessels are in the way of dissection too, meaning the more manipulation or the more dissection, the more likely you are to injure surrounding structures. Also, this will result to a longer operative and anesthesia time, and for a procedure with unclear oncologic benefits, that might not be a good deal. In a large, well-organized meta-analysis of 66 articles encompassing over 275,000 patients, performance of lymph node dissection in prostate cancers did not translate to improved biochemical and clinical recurrence, and offering no survival benefit. Furthermore, lymph node dissection had adverse effect on OR time, blood loss, hospital stay, and post-op complications, like, for example, lymphoseals. The conclusion of this large meta-analysis was that lymph node dissection and its extension had no clear benefit and only appeared to result to worse intra and perioperative outcomes. So bottom line, not all radical prostatectomies will require lymph node dissection. Therefore, proper patient selection is essential and key. Which brings us to the utility of nomograms that predict disease stage and lymph node involvement. And the most famous would be that of Dr. Alan Partin. All of us urologists would have heard of the Partin table of nomogram. So looking at it, it looks toxic and cumbersome actually to use. But a hack I maximize and it's readily available are validated online nomograms. So for instance here, online nomograms such as these on the screen are accessible and are actually free of charge. Your job would just be to key in items such as PSA, clinical stage, Gleason grade, etc. And the percent probability of lymph node involvement will be calculated real time. And there's even provision for MRI-based biopsy, such as this Briganti nomogram from Italy on the right side of your screen. Here's the slow and Kettering nomogram. Now, you might see different nomograms. Most of them have already been compared by studies showing no significant difference. So it's up to actually your preference now. And then you set the threshold. Probably if you 5 to 7% lymph node involvement would be sort of the deciding cutoff for lymph node dissection. So most would, if they see something like above 5% or above 7% likelihood of node involvement, then you will perform lymph node dissection in your radical prostatectomy. Okay. So the fourth hack I want to share is use lymph node dissection sparingly, maximize the use of nomograms. The advantages would be less perioperative morbidity like vessel nerve injury, lymphatic leak, leading to lymphocyl, less operative and anesthesia time if LND can be avoided. Available online nomograms are also very easy to use. Of course, the disadvantage is if improperly staged and lymph node dissection is omitted, then you may inadequately stage pathologically this patient. So important to properly stratify pre-operatively. And now we proceed to the next step of uro hacks, those pertaining to management of metastatic prostate cancer. So this is a slide we often see showing the landscape of prostate cancer as a whole. Take note that as urologists, we are the primary caregivers until late in the castrate-resistant state, when the first and second line modalities have already failed. The field of prostate oncology is among the most dynamic areas of studies. We have two former Nobel Prize winners to thank. First is Dr. Huggins, who together with Dr. Hodges discovered that prostate cancer can be arrested with castration after they experimented with dogs in the laboratory. Next is Dr. Shally, whose works paved the way to understanding of hormonal agents as we know today, and now forms the backbone of androgen deprivation therapy. The fifth hack is well known to everyone but has largely been supplanted by medical treatment. It is, however, still very viable, especially in developing countries like ours, where cost is a consideration. So, is there a role still for surgical castration or orchiectomy? The answer is yes. And we actually have to remember that it's backed by science. So, in an important meta-analysis in the 2000s, Seidenfeld and his team studied a total of 1,900 patients. They compared surgical castration or orchiectomy with LHRH agonist injections, the ones that we use up to this day. With overall survival as the primary endpoint, they concluded that the two methods of castration had no difference. So they are equivalent in terms of overall survival and in other outcomes, including progression-free survival and time to treatment failure. Now, this table neatly summarizes medical versus surgical castration. The advantage of surgical is that there is immediate attainment of castrate level testosterone. No flare is expected, so no need to co-administer with an anti-androgen. So, of course, orchiectomy is way more economical, especially in patients who are trying to save money is an issue. Drawback, of course, is that there's irreversible, and it's irreversible, and there might be some psychological impact to the patient. So, be aware of that. So even in the 2020s, surgical castration as an option should remain in our discussion with our prostate cancer patients, especially when cost is an issue or if compliance and access to hormonal injections are anticipated. So finally, we proceed with the last hack, which I'll discuss with you. So you might see the red asterisk. The reason is this might be a little controversial, and so far, admittedly, no level 1 evidence of data available for this hack, but there are beginning reports showing that it might be possible. So the hack is dose adjustment of hormonal agents like enzalutamide, abiraterone, when given with ADT for metastatic prostate cancer. Now, basing on your goals, you might consider this and discuss this with your patient. Quick review, we see that prostate cancer treatment landscape is rapidly changing. In particular, agents used late in the disease or previously used late in the disease, meaning in the castrate-resistant disease space, is now being introduced as upfront therapies for metastatic prostate cancer at the earliest hormone-sensitive disease space. The different guidelines would now list as level 1 recommendation, giving ADT with an additional agent, either abiraterone, enzalutamide, apalutamide for those with high volume metastatic disease, probably docetaxel. But the sort of the trend now is giving ADT with a combination or with another drug. Okay. So this is just a summary of the big landmark trials, the Charted and Stampede trials support the use of upfront docetaxel with ADT in MHSPC, that's hormone-sensitive disease. The Latitude and Stampede showed superior outcomes with upfront abiraterone with prednisone with ADT. Meanwhile, the Arches and Enzamet showed significant benefit in adding enzalutamide to your upfront treatment. And most recently, apalutamide as an upfront treatment with ADT has been approved based on the Titan trial. Now, all of these agents significantly improve outcomes compared to the standard of care, which is ADT alone, prolonging overall survival among other parameters. That is why now, this is how the NCCN guidelines would look like in 2020. As you can see, the level 1 or category 1 recommendation would be ADT with an additional agent. Likewise, of course, we all know even before that for castrate-resistant disease, the combination therapies would be superior to just ADT alone. The TAX and SWOG studies has established docetaxel many years ago as a treatment. The PREVAIL trial for enzalutamide and the Cougar 302 for abiraterone has established their roles in the castrate-resistant setting. Now, there's no doubt that in metastatic hormone-sensitive and in pre- and post-chemo metastatic castrate-resistant prostate cancer setting, novel AR antagonists and abiraterone provide significant survival benefits, so no question. However, the problem is the high cost of these novel agents. So, for example, abiraterone, which is given 4 tablets, meaning 1,000 milligrams per day, would cost approximately up to 100,000 pesos a month. And then enzalutamide, which is 160 milligrams per day, would cost approximately 110 to 120,000 a month. And probably only 1% of our population can afford this, or maybe even less. Okay, so the question, to offset the high cost without sacrificing treatment efficacy, is a lower dose regimen available or possible? And can these agents be taken intermittently based on PSA or clinical response? So there's a small report on older men, those more than 75 years old with diagnosed castrate-resistant prostate cancer. In this study, although it was a small cohort, they compared standard versus low dose enzalutamide. So their dose of enzalutamide was half dose or lower, so 80 milligrams or lower in the study group. The primary outcome was PSA response. What they reported was that in the 59 patients who were included in the study, there was no significant difference on PSA response and median progression-free survival between the two groups, meaning the standard versus the low-dose enzalutamide group. Of course, as a caveat, we have to remember that this is a small study, and the follow-up period is relatively short, okay? And then another study published in the Journal of Clinical Oncology was done, this time in a developing country like ours, in the Caribbean, and had a similar study population as the one study I mentioned prior to this. So at 3 months follow-up, the standard and low-dose enzalutamide group had no significant difference in PSA results or PSA decline. Okay. Still another study from the UK. This time, what they did was they modified giving enzalutamide. So instead of continuous, they tried giving it intermittently. Okay, this was published in the Journal of Clinical Oncology too, so it's a reputable journal. So they included patients on treatment from 2011 to 2018, and those who were with significant side effects from the treatment were given 1 month break. So that's how they were able to come up with this review. And using Kaplan-Meier analysis, using enzalutamide intermittently, meaning giving breaks when they see side effects, did not appear to affect overall survival curves. So again, of course, this is a small retrospective study. But you know, we have some data. So if you'll come to think of it, you might be able to consider it in your real life practice. Okay. And then finally, of course, the use of low-dose abiraterone. Somewhat, they have more data. They actually have a phase 2 trial from the US and Singapore to support this. Okay, the study randomized 36 patients each. So 36 to the standard dosing, and then which is the 1,000 milligram per day, and then 36 to the low dose, 250 milligrams with low-fat food. That's to improve its absorption. And then, of course, this was given with prednisone, 5 milligrams. And then the primary outcomes measured was the PSA change and progression-free survival, change in testosterone, as well as pharmacokinetics were other outcomes that were measured. These graphs show the PSA logs of the two different groups. The findings only show that low-dose abiraterone was non-inferior to the standard dose in terms of PSA metrics. Although again, of course, at the end of the conclusion, long-term follow-ups are needed. Larger RCTs, ideally multi-center, multinational, are ideal. So we can see the real picture or the real effect of comparing or giving low-dose abiraterone. Okay, so we need to establish this more. But there's some data. Okay, so the last hack I have, albeit still controversial, is that of adjusting the dose of novel agents added to ADT. So advantages. There are some studies already showing clinical benefit of these lower dose hormonal agents, potentially better side effect and toxicity profile since they are lower dose. Cheaper because they'll need less medication, and because of the cheaper cost, this can also translate to better compliance for the patient. So sample calculations would be if you take the 250 milligram per tablet dose for 1 month, that would only be 24,000 a month instead of the approximately 90,000 pesos a month with the standard dose. And then for enzalutamide, for example, instead of the 160 milligram, for example, if you give 80 milligrams per day, then that would cost 55,000 a month instead of the over 110,000 a month with the standard dose. So, these things we're looking at, worth considering. There's still lack of level 1 data, not yet enough science to back this. So you need to explain this to this patient. But so far from the small studies, from the initial reports that we're getting, there seems to be somehow comparable or acceptable oncologic results. Okay. So this is my last slide. This is the summary of the uro-oncology hacks we discussed. I am sure that each one would have his or her own little trick in urology practice. And I think that the beauty of it is we can learn from each other. So therefore, I look forward to learning from you as well. Okay? So once again, thank you to everyone. And salamat po, PUA Mindanao.